What is the minimum symptom duration required to make ICD-11 diagnosis of schizophrenia? So it is 1 month. That is perfect for ICD-11 diagnosis of schizophrenia. A symptom duration of at least 1 month is generally required. So at least 1 month is required, and then it says with DSM-5 psychotic symptoms criteria A needs to be present for a month, while the total duration of disorder itself should be 6 months. So the question is asking regarding ICD-11. So in ICD-11, its symptoms should be present for at least 1 month. And according to DSM-5, psychotic symptoms like criteria A needs to be present for a month, while the total duration of disorder itself should be for at least 6 months. That's perfect. Yeah. Which of the following statement regarding PTSD is true? So in PTSD, they have specific criteria, so that they will be have flashbacks. They will be very vigilant all the time, and that's a very important thing in PTSD. Uh, so in PTSD, that is the most important thing. And now, now it says specific EEG changes occurs in chronic PTSD. I'm not really sure. I don't think so. Previous history of neurotic illness preclude the development of PTSD features. PTSD is associated with hypersomnia. PTSD symptoms usually occur within 6 months of the trauma. Autonomic hyperarousal symptoms are usually rare. That is incorrect. EEG changes, I'm not sure. History of neurotic illness precludes the development of PTSD features. That is incorrect. So PTSD associated hypersomnia, that's also not symptoms or occurs usually within 6 months of trauma, I would say. That is the most important thing. That's correct one. So there's a tick mark here. So now this says symptoms of PTSD usually arise within 6 months of traumatic event. There is delay onset in approximately only 10%. So 90% of patients will come to the doctor with PTSD symptoms, and they would say that this thing happened and this thing is causing this thing in their life. After this incident, this thing start happening. So the essential feature of PTSD are autonomic hyperarousal, which is that they will be very, very aroused easily. They will be very, very exaggerated. They will have exaggerated startle response, re-experiencing of aspects of the traumatic event, and active avoidance of cues that remind the person of the trauma. So they will not go to anywhere which is related to the trauma he or she has been through. Insomnia is common, so they are not sleeping. They are not always in the bed. No, that's wrong. They are not in the bed. In Hedonia is may also be seen, so they will not be they like a depression. Vulnerability factor for PTSD include low self-esteem. It's very common in those people with low self-esteem, neurotic traits, and previous or family history of psychiatric problems, especially mood and anxiety disorder. So if someone has mood and anxiety disorder in the family, or um, so they will have PTSD easily. These are the risk factors. Mr. Z was admitted to a psychiatric ward 7 days ago. On mental state examination, he appeared thought disorder and also had mood incongruent delusions. So this is Mr. Z, who has been in psychiatric ward 7 days ago. So he was thought disorder. He had thought disorders, and he also had mood incongruent delusions and hallucinations. So he had both these things. So Mr. Z was there mood and congruent delusions and hallucinations. I am not really sure about mood incongruent delusions and hallucination. At times he would laugh inappropriately. What is the most appropriate diagnosis? So this guy is has thought disorders, mood incongruent delusions and hallucinations, and would not be like laughing without any reason. So this is more schizophrenia, I would say. So this is schizophrenia. So we can have a look. What is it's saying? Mood incongruity, such as inappropriate laughter. So it is smiling, buffoonery, or weeping has been considered an important sign in schizophrenia. So it is like if someone is crying and then is sad, is unhappy, mood is very low down, and then he starts laughing. That's not a good thing. Important signs in schizophrenia. So it is not specifically included in current diagnostic system. It has aided in DSM-3 and dropped in DSM-4. Mood congruent describes a secondary symptoms which is understandable in light of an abnormal mood state. For example, severely depressed patient developing a delusion that they are in severe debt, and a manic patient developing a delusion that they are exceptionally wealthy. So yeah, that is the point. So it's mood congruent. So mood congruent. So manic patient is manic, so he thinks he's happy, wealthy, and then the patient is depressed, and then he thinks accordingly. Mood incongruity is like mood is one thing and response is different. So this is perfect. So it's not an inclusion or exclusion criteria. So now going to question number 26. 25-year-old man has experienced an irrational fear of darkness since childhood. So this guy is 25 and from the very young age he's afraid of darkness. He's not distressed by his currently and does not take special measures to avoid dark spaces. Which of the following is true? Is currently and does not take special measures to avoid dark spaces by this currently. So he's not distressed by this currently. Has experienced an irrational fear. So now he's fine and he measures what is which of the following. He has specific phobia as he has irrational fear. He has not specific phobia as fear of darkness is common. So he has no specific. He has a specific phobia with way loss of insight. He has no specific phobia as he does not have an avoidance behavior. Phobia as he has it since childhood. No, I would say this one is correct. He has no specific phobia, and if it was phobia, he would have the avoidance behavior. So he has not specific phobia as he does not have an avoidance behavior. So that is a him actually. In phobias of all kinds, there is an avoidance of the feared situations. So in phobias of all kinds, there is an avoidance of the fear situation. Specific phobias are restricted to specific situations such as proximity to certain animals, natural phenomena such as height, thunder, darkness, flying, being trapped in closed spaces, urinating or defecating in public toilets, eating certain foods, dentistry, or the sight of blood or injury. So in phobias of all kinds, there is an avoidance of the fear situation. So now the point is that as no one is watching, so we can say that phobias of all kinds, there is an avoidance of the fear situation. Specific phobias are restricted to specific situations such as proximity to certain animals, natural phenomena such as height, thunder, darkness, flying, being trapped. There is an avoidance of the fear situation. So if there's phobia, they will be avoiding. Specific phobias are restricted to specific situations. So that's perfect. So if this guy has no avoidance, then it's not phobia. Which one of the following is an ICD-11 diagnostic feature of the frontotemporal dementia? So frontotemporal region, if this is involved in sinus onset and gradual progression, 6 months history of cognitive decline, memory impairment precedes behavioral manifestation, older age onset, abrupt onset. So I think memory impairment is after the behavior. No, this is not correct one. So what is the correct option? Insidious onset and gradual progression. So frontotemporal dementia has insidious onset and it will progress gradually. So in ICD-11 characterizes frontotemporal dementia, which is called as FTD, as a group of primary neurodegenerative disorder primarily affecting the frontal and temporal lobes. Onset is typically insidious with a gradual and worsening courses. Onset is typically insidious with a gradual and worsening course. Several syndromic variants are described that include presentations with predominantly marked personality and behavioral changes, are with predominantly language deficit, are with a combination of these deficits. Memory function, psychomotor speed, as well as visual perceptual and visual spatial abilities often remain relatively intact, particularly during the early stage of disorder. So ICD-11 characterizes frontotemporal FTD as a group of primary neurodegenerative disorder primarily affecting the frontal and temporal lobes. Onset is typically insidious with a gradual and worsening course. Several syndromic variants are described that include presentations with predominantly marked personality. So they have predominantly marked personality, behavioral changes are with predominantly language deficits are with a combination of these. So they might have language deficit, behavioral issues, or personality. So memory function, psychomotor speed, as well as visual perceptual and visuospatial ability often remain relatively intact, particularly during the early stages of the disorder. Which one of the following is not known to be associated with an occurrence of psychotic features during the episode? With an occurrence of psychotic features. Current episode of mania, psychotic depression, acute or transient psychotic disorder, hypomania, schizoaffective disorder, associated with the occurrence of psychotic feature during the episode. The occurrence of psychosis. So, which one of the following is not related to, did not cause psychotic features? Bipolar affective disorder, psychotic depression, and acute and transient psychotic disorder, hypomania, and schizoaffective disorder. I think schizoaffective has no, or hypomania. This is one, or hypomanic episodes that have no psychosis. So, psychotic features are not seen during the hypomanic episodes. The clinical features of hypomania include elated mood, increasing energy levels, excitability, lack of sleep, over optimistic ideation, and expensive mood. By definition, is severe enough to interfere with social or occupational functioning, require admission to hospital, or include psychotic features. So hypomania, you don't need to admit the patient. So, and you don't see psychotic features. The clinical features of hypomania include elated mood. So, mood is very high, increased energy level, excitability, lack of sleep. So, over optimistic ideation. So, the optimistic ideation and expensive mood. Hypomania is not severe enough to interfere with social occupational functioning, require admission to hospital, or include psychotic features. So the next question is following the death of 85-year-old mother 4 months ago, 49-year-old receptionist has become increasingly convinced that the prime minister is in love with her and that they have an ongoing affair. She has clear thought and no hallucinations. So this is just thought and no hallucination. She's doing well at work and has no issues with her husband. Which of the following is the most likely diagnosis? Delusional disorder, acute reactive psychosis, paranoid personality, prodromal schizophrenia. Delusional disorder, I would say. So she's delusion. So delusions without hallucination and thought disorder, along with preserved family and work functioning, are suggestive of delusional disorder. So, if someone is delusions and they don't have hallucinations or thought disorder, and they are able to maintain the work and able to maintain the family life, they are delusional disorders. Delusional disorder is an uncommon present with circumscribed symptoms of uncommon delusion condition in which patient present with circumscribed symptoms of non-bizarre delusion. Okay, so now